as we are running short of time, I would request all the speakers to please strictly stick to the time. To start with, may I request Dr. Ashok Velodi, who will be speaking on management challenges in lysosomal storage disorders, case-based discussion. Dr. Ashok Velodi has done MBBS from Pune and MD from All India Institute of Medical Sciences, Delhi. He has done MRCP in pediatrics and he is presently working as a consultant pediatrician, metabolic unit, Great Ormond Street Hospital for Children and NHS Trust, and an honorary reader at the UCL Institute of Child Health, London. Dr. Velodi, please.
Yeah, don't connect it just yet. I just want to find
Cancel.
format for this.
No, cancel.
Cancel. Okay.
Just remove it. Okay, just I will.
Thank you very much. I'll try and be brief and not keep you from your lunch. So in the interest of time, I'll move quite quickly. Just a couple of things to say. First, that I am not a geneticist. I'm a pediatrician by training, but I've looked after children with lysosomal storage disorders. And the second thing to say is that there are pictures of patients in this, and I have looked after these patients personally and received informed consent for showing the pictures. Okay, so I'm just going to show you 5 cases. I had to select them from my personal practice, and they illustrate different aspects of management of lysosomal storage disorders, and I'll try and have some sort of discussion around each case. So the first case is William, a child with MPS 1. He presented at 1 year of age. He was felt to have Hurler-Scheie disease, which is the intermediate form of MPS 1. This was his genotype. It actually falls, it could be either Hurler's disease or Hurler-Scheie disease, so it was quite difficult for us to make a diagnosis based on genotype. But we felt he had Hurler-Scheie disease. The treatment of choice for Hurler-Scheie disease is enzyme replacement therapy. Sorry, this is the reference in which the genotype was published. There was no clinical improvement at all. And after about a year, about that, there was also no improvement in the biomarker, the urinary GAG-creatinine ratio. So the question is, what do we do next? Most children with Hurler-Scheie, you would expect some improvement. So we checked his antibodies, found that he had very high levels of antibody to algeurozyme, which is the enzyme that we give, and he had a complete inhibition of uptake of enzyme. Okay, so this is very important. Most patients with MPS 1H, that's Hurler's disease, not Hurler-Scheie, they develop antibodies to ERT. Okay, that is why you should not treat Hurler's disease with enzyme replacement therapy for too long. After about 13 weeks, they develop antibodies, and the majority develop inhibitory antibodies. There are 2 types, those which inhibit catalytic activity and those which inhibit cellular uptake. And patients can have both types. In the case of William, he had no inhibition of catalytic activity, but inhibition of cellular uptake. So he is sort of intermediate. He wasn't too severe. So we were hopeful that he would improve as time went on. However, the question arose is what to do next. We therefore proceeded to stem cell transplant. The reason was that because he had developed inhibitory antibodies, we felt that he was behaving more like a Hurler's disease than Hurler-Scheie disease. And we felt that it would not be correct to continue with enzyme replacement therapy. So he had a transplant. And there's been a recent paper which shows that even in some patients with Hurler-Scheie disease, a bone marrow transplant may be considered. So we weren't too worried about the ethics of doing a transplant at his age and for his type of disease. Now, the Manchester group have published the antibody formation following enzyme replacement therapy for MPS 1. This was the group discussion. I talked to you about whether to do transplant for MPS 1H or not, or for the milder forms. And this was the European consensus reference that was published. So anyway, he proceeded to stem cell transplant. He had full engraftment, but there was no improvement in antibody levels at all. And this was very curious. The Manchester group have shown that following a stem cell transplant, the antibody levels improve. So the median time to high immune response following enzyme replacement therapy, this is the second row, is about 55 days. But 1 year post-transplant, you look at the bottom row, virtually 100% of patients have developed immune tolerance. So it was very strange that William had not. And he was, as far as I know, he was virtually the first patient who did not follow this timeline. So the question was whether he had recipient plasma cells that had been programmed by his B lymphocytes, and I'll talk about that a little bit later on. So he was given a monoclonal antibody called rituximab, and we kept bortezomib, which acts on plasma cells, as a backup if required. A few days after his starting treatment, he was admitted as an emergency with no movement below the neck. The MRI scan earlier that year had shown significant cord compression at the cervical cord level, and the neurosurgeons were considering emergency surgery on his neck. But on careful taking of a history, we found that he actually had pain in his limbs, and his hands were swollen. So we made a diagnosis of Arthur's reaction, type 3 reaction to rituximab, so we stopped it, we treated him with steroids, and he made an uneventful recovery and a slow decline in antibody levels. So that's the first case. The second case revolves around MPS II. This is a female with MPS II who had non-random X inactivation. Her normal monozygotic twin had equal use of both X chromosomes. Now, as you know, monozygotic twins don't always follow the same patterns of X inactivation. So it is not surprising that her twin had random X inactivation. She also, if you look carefully, she had facial asymmetry. In fact, it was not just facial asymmetry, she had total hemihypertrophy, and we've never found an explanation for this. The point was that it was less the science of all this than the psychological effects. So you can imagine, by this time, her twin, who was, she was a very charming young girl, she had found a partner, she was having a normal life, whereas Naomi was unable to because of these problems. She was extremely intelligent, I have to say. Okay. As you know, MPS II in females may be caused by structural abnormalities of the X chromosome, homozygosity for disease-causing mutations, or skewed X chromosome inactivation. The majority fall into the third group. Happily, she found a partner, she conceived, she refused prenatal. At this point, she was also found to have Ehlers-Danlos syndrome, and we were quite worried about the effects of the pregnancy on the fetus. As you know, there is a morbidity and mortality associated with the vascular forms of Ehlers-Danlos. Fortunately, she did not have a vascular form, so the pregnancy, in that sense, proceeded uneventfully. The question was how to manage it, because she was receiving enzyme replacement therapy at this time. So there were various options to consider. This was the first pregnancy reported in Hunter's disease on ART. So should we stop pregnancy completely? Should we continue it throughout pregnancy, or should we stop it for part of the pregnancy? And there was no guidance from anywhere. So we stopped it in the first trimester to avoid teratogenicity. She delivered a male child who was affected. The genotype predicted his phenotype to be severe. So his mother was obviously protected from the severe effects by the fact that she was female, but her son would not be. Anyway, he was commenced on enzyme replacement therapy immediately and carefully monitored. But very soon, early assessment showed that he had inappropriate play, and we felt that this was early evidence of neurological involvement. So we were in a dilemma, because the question is what to do. Should we stop enzyme replacement? Should we increase the dose? Should we continue to bone marrow transplant? Should we do nothing? We opted for a bone marrow transplant. And now this is a very difficult situation. There are essentially two forms of Hunter's disease. On the left, you see a child who has non-neurological form. On the right, the neurological form. For the child on the right, you would not give enzyme replacement therapy, and for the one on the left, you would. It's to prevent neurological problems that we even consider a transplant. Now, here you have two pictures. The left is a child with Hurler's disease, MPS 1H, and that's a child with Hunter's disease. And it's quite striking that whereas bone marrow transplant is quite successful in Hurler's disease, it is not successful in the neurological forms of Hunter's disease, and nobody's very clear why. The early reports suggested a very poor neurological outcome, but very few transplants have been done at an early age. There are 3 papers that have been published, and as you can see, varying numbers of patients and varying ages, but one of the youngest patients was in our group, reported quite some time ago now. This is the child in question. He had a transplant at the age of 9 months. He was asymptomatic, diagnosed on the basis of a family history. His maternal uncles were affected and died in late adolescence. The genotype showed a frameshift mutation creating a stop codon in exon 2. So he was transplanted. That's him in his, I think it's about 20. He had a shunt for hydrocephalus at the age of 15, despite the fact that he had transplant. He left school. He was unable to complete higher education. He has a lot of difficulty with independent living and still lives at home. So it's not he's not been a huge success in that sense, but his quality of life is relatively good. So anyway, we thought about this a lot, discussed it with other centers in the UK. We were aware that at that time Duke University had started a program in transplanting Hunter's disease early, but there was no published data. Anyway, we decided to transplant him. So he proceeded to transplant. He had full engraftment, but his urine GAG-creatinine ratio showed no improvement at all. And that is very strange, because following a transplant for Hunter's disease, based on earlier experience, we would expect the GAG to come down quite dramatically. So we tested him, and we found that he had undetectable plasma enzyme activity, but normal leukocyte activity. So what does that mean? Okay, why should a child with Hunter's have undetectable plasma activity, but normal leukocyte activity? Now, in Hunter's, enzyme is measured in the plasma. It's not measured in leukocytes. Okay, that's a technical issue. It could be because this child had antibodies, circulating antibodies. So when we look at the plasma, the antibodies just neutralize the enzyme, and we don't see any activity. And sure enough, that's what we found. We had neutralizing antibodies. So we treated him with rituximab. He had a severe reaction. Rituximab is an anti-CD20 monoclonal antibody, a severe reaction to it, so we stopped it. We switched him to ofatumumab, which is another monoclonal, which he tolerated well. But really, there hasn't been much change in his GAGs or plasma activity. Having said that, he is growing with good neurodevelopmental progress, so that's a puzzle. Just to let you know that there's been a recent publication from the States of successful reduction of sustained antibody titers to enzyme in MPS 2 by immunomodulation, and Priya Krishnani's talked about that in detail, so I won't go into that, but basically it's a combination of these drugs. So just to remind you that B cells secrete antibodies. They are in the germinal centers of the splenic pulp. They mature to plasma cells, which travel to the bone marrow. And you get these short-lived plasma cells and then long-lived plasma cells. Following a transplant, recipient B lymphocytes disappear very quickly, but the recipient plasma cells persist for much longer. Okay. So you've got long-lived plasma cells in the patient whom you've transplanted, which are mediating humoral immunity for long periods without any B cells. And therefore, immunity acquired pre-transplant may persist post-transplant. And this is a very important concept, which I don't think we had fully realized, but at least this was our theory for why this patient may not have responded. He might have had plasma cells of his own plasma cells which had not disappeared. Now, it's very difficult actually to test for plasma cells in the circulation, so it was just a theory. So the points to consider in this case is that from a quality control point of view, the enzyme is normally present in the plasma, not leukocytes, so our leukocyte measurements might not have been very accurate. Nevertheless, it was completely normal, which is really striking. The leukocytes, which are normal, might have crossed the blood-brain barrier and conferred benefit to the brain. So that might be why, despite the fact that no enzyme in the plasma, he was continuing to develop cognitively. The question was, what cells were we targeting? The donor cells, the recipient cells, B lymphocytes, the plasma cells. Anyway, the point about these two cases is that poor response may be related to antibodies. So case 3, a 6-year-old boy, he was diagnosed as MPS II. He was treated with enzyme replacement therapy, and there was no improvement after 2 years. He was retested and found to have MPS VI. So obviously the original testing showed a wrong result. It was done in a lab which was not accredited, with relatively less experience. So this is a fundamental point, that quality control and accreditation of laboratories is absolutely critical if you want to look after these patients. So poor response may be related to something as simple as a wrong diagnosis. And it's very easy once the diagnosis, because these patients look similar, once the diagnosis is made, you start enzyme replacement therapy, you don't rethink, well, could this be the wrong diagnosis? And that's a really important teaching point. So case 4 is an 18-year-old boy, a young man, with MPS IVA, Morquier's disease. He presented to the adult clinician for the first time, complaining of visual difficulty, and on examination was found to have a homonymous hemianopia. So why would he have a homonymous hemianopia? So careful history was taken, and he gave a history of dizziness for the past week, and importantly, he had not had a cervical fusion. Okay, so in Morquier's disease, you do a cervical fusion to protect their cervical cord. The MRI scan showed vertebral basilar ischemia. Okay, this is a rare complication that, I mean, it's rarely described in Morquier's disease, but it's probably commoner than we think. There are, a number of reports of sudden death in Morquier's, which may be related to ischemia of the brainstem. And then when they went into the history, actually he was our patient, but he had sort of defected from our clinic and reappeared in the adult clinic without telling anybody. He had refused cervical surgery. He had actually got cervical instability, but had refused. As long ago as 1981, it was shown that abrupt changes in head position can cause cerebral infarction. Even in normal people, you can get physiological changes, so that the vertebral artery, this is the vertebral artery, and you can see that the third part, it sort of loops from the C2 to C1, and that's where the problem arises. So when you get rotation of the cervical spine, the vertebral artery gets stretched over there. Now, in humans, there's no compensation. Interestingly, for example, in some birds, such as owls can rotate their necks through actually 360. The vertebral artery above here dilates in owls. It provides a pool of blood, a reservoir. There's no such mechanism in humans. So that is probably why this patient had problems. So points to consider in this patient was that he was an older patient, and therefore we got a phenotype that we don't normally see in children. He'd had no previous surgery, and he had presentation with visual problems, which is quite rare. Okay, case 5. Is a child...
Excuse me,
who-
sir, we are running short of time, so would request you to please summarize it.
Okay, so we'll stop. Thank you very much.
The next speaker on Dr. Neerja Gupta, and she is MD Pediatrics from BHU, and she did DM Medical Genetics from SGPGI. She is also involved in the regional networking of the birth defect in Southeast Asia region. She is currently assistant professor in Division of Genetics in AIIMS Delhi. She has received, she have recipient of Clinical Genetics Society Fellowship in UK 2012, and she has several publications on her repute. So I think over to Dr. Neerja Gupta.
Good afternoon, everyone. Thank you, chairpersons, for the kind introduction. At the outset, I would like to thank the organizers, especially Dr. Kuldeep Singh and Dr. Soni, for giving the opportunity and rescheduling my talk. So I have been given a task of describing cytogenetic microarray as a revolution in diagnostics. So the outline of my talk would be covering some basics related to karyotyping as well as chromosomal microarray. And being a clinical geneticist, the application in the clinical genetics will be discussed in postnatal and the prenatal scenarios. I will not be covering the cancer cytogenetics array in this talk. So we all know that the common indications for a cytogenetic test can be either multiple malformation syndromes, dysmorphology, dysmorphic patients with dysmorphism and developmental delay, or disorders of growth, short stature, or overgrowth. Now, there has been evolution over last 30 years. Till 30 years back, we had conventional chromosomal analysis as a method of test for such patients. And in the next 20 years, there was development of, with the advancements in technology, the techniques like fluorescent in situ hybridization, that is FISH, and chromosomal microarray on chips had come. So to understand the basic difference between the two, karyotyping is basically a genome-wide analysis where you look at the various chromosomal abnormalities at a low resolution of about 5 to 10 MB. It detects only 4% of the patients. Whereas in FISH, which came up in 1990, so the resolution is little higher. It is site-specific, but it requires a prior knowledge of that particular syndrome to order for that particular test. Then there was a need to develop a test which can cover the whole genome as well as has the high resolution like FISH, and so that the detection rates can be improved. So with chromosomal microarray, it is genome-wide. There is higher resolution, and it can detect about 15 to 20% of the patient. So let's see what is the basic difference between the karyotype and array. Karyotype visualizes chromosome, whereas array is a DNA-based test. Karyotype requires dividing cell, whereas array does not require any dividing cells. Karyotype is